Welcome to another TIROxMDS session, where each week we bring in leading experts in the field of thyroid cancer to discuss the current advancements in thyroid cancer, thyroid diseases. Their research is extremely important to us, and these webinars have been extremely well received around the world. I keep watching them again and again and learn more every time I watch it. Today, we are extremely fortunate to have two outstanding endocrinologists, Dr. Debbie Chen, who is on the faculty at University of Michigan. She was trained in Rochester and Philadelphia, and her special expertise is disparities in thyroid cancer. And you will love her presentation on distant metastases and the review of SEER data. I'm extremely fortunate also to introduce my colleague, Dr. Stephanie Fish, who is an outstanding endocrinologist with special expertise in the field of thyroid cancer. Her addition to Memorial Sloan Kettering has brought in a special field in endocrinology and association between surgeons and endocrinologists. So, Stephanie, welcome. Be sure to tune in for the Voices of Wisdom, our podcast dedicated to the field of medical profession in thyroid cancer and treatment of thyroid cancer. Each month, we explore expert insights and groundbreaking research. Catch the new episode every third Tuesday of the month and stay ahead of thyroidology. Our current moderator is Dr. Dana Hartel from France, and she does a great job in bringing up world experts and bringing their decision-making in the management of thyroid cancer. Without further ado, I would like to invite Debbie to give her presentation regarding distant metastases. Debbie, you are on.
Thank you. Thank you so much for having me here today. So I'll be doing Journal Club on our manuscript that was published entitled Survival Prognostication in Patients with Differentiated Thyroid Cancer and Distant Metastases. And this is based on a SEER Population-Based Study. So I have no financial disclosures. And then to start with, I wanted to give some background on thyroid cancer, just so to set the stage for the premise of the study and the reasons that it's important. So thyroid cancer is the most common endocrine malignancy in the United States, as well as in the world. And at least in the United States, it was responsible for more than 52,000 cases in 2022. And so while thyroid cancer affects both men and women, the incidence rate in women is 3 times higher than that in men, with thyroid cancer representing about 1 in every 25 cancers diagnosed among women. And while this data I'm presenting is for the United States, it is very similar when we look at the international data as well. So while the overall prognosis for most patients with thyroid cancer is excellent, the clinical outcome is variable and it's influenced by factors such as patient age, histologic subtype, and presence of metastases. So if you look on this figure here, in which you're looking at 5-year relative survival rates with the percent in the y-axis and then the staging, the type of staging on the x-axis, you can see that at the time of survival, at the time of diagnosis for patients with thyroid cancer, 5-year survival rates, they range anywhere from 52% for those with distant metastases to almost 100% for those with localized disease. And since distant metastases in differentiated thyroid cancer is generally associated with worse prognosis, it occurs in less than 10% of patients with differentiated thyroid cancer. And so correlates of survival in this patient population is pretty understudied. So historically, patients with metastatic thyroid cancer, they had limited treatment options. But since 2013, a number of systemic therapies that I've written on the slide here, they've been approved by the FDA for the treatment of locally advanced or metastatic RAI refractory differentiated thyroid cancer. And so in this context, it's important that clinicians are able to risk stratify their patients with metastatic thyroid cancer and that they're able to identify those patients who are at risk for worse outcomes who may benefit from early initiation of systemic therapies or enrollment in clinical trials. And so the development of comprehensive prognostic groups for thyroid cancer patients with distant metastases is quite important to tailor treatment to disease severity. And this was the basis for the study. So the objective of our study was to, one, identify prognostic groups among adult patients with differentiated thyroid cancer who presented with distant metastases, and two, to determine the role of and interactions between patient and tumor characteristics in determining survival. So we use the SEER Cancer Registry to identify adult patients that was diagnosed with differentiated thyroid cancer and distant metastases at initial staging. So SEER stands for Surveillance, Epidemiology, and End Results, and it's an agency that collects comprehensive cancer incidence and survival data from population-based cancer registries. And in the United States, it's considered one of the premier sources of cancer statistics. So we use the SEER 17 registry, which collects data from 17 geographic areas. The thyroid cancer diagnosis was based on ICD-9 or 10 coding, and then patients without complete records of variable or survival outcomes, we excluded them from the study. So we extracted a number of variables from the SEER database. So we extracted patient characteristics, tumor characteristics, as well as treatment characteristics. So for the patient characteristics, we obtained data on the age at time of diagnosis, sex, race, ethnicity, county level median household income, as well as county type, so either metropolitan versus non-metropolitan. For the tumor characteristics, we obtained data on the histologic subtype, the size of the primary tumor, which we subsequently characterize as less than 2 centimeters, between 2 to 4, and greater than 4 centimeters, as well as the site of distant metastases, and that we categorize as bone, brain, liver, lung metastases, or other. And then in terms of the treatment characteristics, we obtained data on the surgery type, radiation therapy, if any was received, specifically radioactive iodine therapy, and whether chemotherapy was received or not. And then in terms of the primary endpoints, we looked at disease-specific survival, which we defined as the time from thyroid cancer diagnosis to death from thyroid cancer. We also looked at overall survival, which was the time from thyroid cancer diagnosis to death from any cause. So to go into our methodology, I want to take a couple of minutes to go through the main differences between the types of analyses that we performed. So we performed a Cox proportional hazards regression, which was used to model the disease-specific and overall survival as a function of patient and tumor characteristics. And so in this model, we did not include treatment characteristics as a variable because most cancer staging models in the literature, including the AJCC staging for thyroid cancer, is performed at the time of diagnosis. And so it's based on only patient and tumor characteristics, similar to what we had performed. And then we use what is referred to as tree-based methods, which allows for the capture of nonlinear and heterogeneous effects and can automatically detect interactions without having the need to identify or specify those interactions a priori. And so specifically, we perform survival tree analyses on disease-specific and overall survival to construct distinct prognostic groups. Kaplan-Meier survival curves were then generated for each of these distinct prognostic groups and compared to each other using two-tailed log rank tests. And then 5-year survival rates were calculated as a summary measure for each of these final prognostic groups. So in terms of our study results, in our cohort that had patients identified between 2010 and 2019, we identified more than 2,400 patients with differentiated thyroid cancer and distant metastases. They were followed for a median time of 62 months. The median age at the time of diagnosis was 62 years. Most of the patients in the cohort were female, white, and non-Hispanic. Most had papillary thyroid cancer, so 86% had papillary thyroid cancer. And the most common sites of distant metastasis was the lungs, which occurred in 33% of the cohort, and the bone, which occurred in 18% of the cohort. And then 84% underwent a total thyroidectomy, and 58% received adjuvant radioactive iodine therapy. And during the study period, 23% died from thyroid cancer, and 31% died from all causes. So based on the Cox proportional hazard regression analyses, we found a statistically significant association between survival and age at the time of cancer diagnosis, size of the primary tumor, and site of distant metastasis. So in terms of age, which is highlighted in this red box on the screen, we found that older age at the time of diagnosis was associated with worse disease-specific as well as worse overall survival. And so the important point to highlight is that since age was analyzed as a continuous variable in this model, the hazard ratio that you're seeing here for disease-specific and overall survival, so the 1.05, that is for the hazard ratio represents that for an increase of 1 year of age. And then if we look at the size of the primary tumor, this was also found to be an important predictor of disease-specific and overall survival. So for example, if we look at column 3, in terms of disease-specific survival compared to tumors that was less than 2 centimeters in size, the hazard ratio for those that were 2 to 4 centimeters in size was 1.47, and the hazard ratio for those that was greater than 4 centimeters in size was 2.91. And so distant metastases to the bone, brain, lung, and liver were also important predictors of survival. And so an important point that I want to highlight here about the Cox proportional hazard regression model is that it identified variables that have a global effect and is associated with the outcome. So for example, within the cohort of patients with differentiated thyroid cancer and distant metastases, those with brain metastasis, which is highlighted in this red box here, have a 3 times greater odds of dying from thyroid cancer compared to those with non-brain metastases. And that's what you see in the column 3. And then the next few slides, we focus on the results of the tree-based methods that were used in our study to generate prognostic groups and to detect interactions. But before I go into the results, I want to first describe what is accomplished with the survival tree methodology. And so what it does is that it splits the cohort of patients with differentiated thyroid cancer and distant metastases into 2 groups, so group 1 and group 2 in this example, based on all the variables that we put into the model, such that group 1 and group 2 are alike within the group, but they're different between groups in terms of prognosis. Then the survival tree methodology keeps splitting into branches, and each subsequent split separates the cohort into groups that are similar within the group, but they're different between groups in terms of prognosis. And so what happens is the model naturally defines prognostic groups without specifying presumed categories a priori. So this is a figure that shows a survival tree for disease-specific survival. And so at each level of the tree, we show the best splitter. The circle at the bottom, they denote terminal groups in the tree. And then the information within the circle, we at the top report the 5-year disease-specific survival rate. Then the middle number is the total number of patients in the terminal group. And then the bottom number is the accrued number of patients who died from thyroid cancer in that terminal group. And so what you see here, and it's highlighted in yellow, is that the first split in the tree is by age of less than or equal to 57 versus greater than or equal to 58 years old. And then the subsequent splits, which you see highlighted in green, like orange and or yellow again, they were based on presence or absence of lung metastases, age, and tumor size. And so in the end, there were 3 prognostic groups that you see highlighted in red, purple, and blue. And so group 1, which is highlighted in red, it has the highest 5-year disease-specific survival. Group 2 is highlighted in purple, and then group 3, which is highlighted in blue, had the worst 5-year disease-specific survival. And so in comparison to the Cox proportional hazard regression model that we had discussed in a couple of slides prior, that had identified variables with a global effect on outcome. The survival tree analyses identify variables that have a subgroup effect on the outcome. And so in this context, the survival tree analyses found that the presence or absence of lung metastases has a subgroup effect that may not necessarily be important across the entire patient cohort population. So for example, while the presence of lung metastases, as you can see here, that's highlighted in green, it has a subgroup effect on prognosticating disease-specific survival in patients that are aged 58 to 72 years with a tumor of less than or equal to 4 centimeters. It did not or is not important in prognosticating disease-specific survival in patients highlighted in this kind of orange highlight, patients aged greater than or equal to 83 years with tumor sizes of greater than 4 centimeters. And then this is another important point that I wanted to highlight. So in our study, age was used as a continuous variable in the survival tree analyses. And And so it naturally divides the cohort by age groups that are most important for prognosticating disease-specific survival. So in this figure here that's on the screen, you see that the first split in the tree was by age less than or equal to 57 years versus greater than or equal to 58 years. And so notably, this is different from the age cutoff of 55 years that's used in the 8th edition of the AJCT staging for thyroid cancer. And I think it's important to recognize that the age cutoff of 55 was predefined based on analyses that included a much more general cohort of patients with thyroid cancer, whereas our specific study had a patient cohort with differentiated thyroid cancer and distant metastases. So that's a higher risk patient cohort. And then looking on this slide, so the figure on the left illustrates the Kaplan-Meier curve for disease-specific survival for each of those 3 distinct prognostic groups that was identified in the prior slide. And as you can see, the group 1, which is at the top of this line, the solid line, that had the most favorable outcome. And group 3, which is at the bottom line, that's dotted, that had the worst survival. The table on the right, it provides column 1 is the group 1, 2, and 3. Column 2 is a description of the patient tumor characteristics of each group. And then column 3 shows the disease-specific survival over a 5-year period. And so that was 92% for group 1, 64% for group 2, and 41% for group 3. So then moving on to the analyses that we performed for the overall survival. So this shows the survival tree for overall survival. And so similarly, the first split in the tree was by age of less than or equal to 57 years versus greater than or equal to 58 years. And then all subsequent splits that you see with the green, orange, and yellow highlights, they were based on presence or absence of lung metastases, age, and tumor size. And in the end, we had 4 distinct prognostic groups. So group 1 is in red. That one had the highest 5-year overall survival. Group 2 is in purple. Group 3 is in blue. Group 4 was in yellow. And group 4 had the worst 5-year overall survival. So then similarly, when we look at the Kaplan-Meier curve for overall survival, we see group 1, which is a solid line at the top, and then this alternating dot and dash line of group 4 at the bottom that had the worst prognosis. The table on the right shows group of 1 through 4 in column 1, the description of the patient and tumor characteristics for each group in column 2, and then the 5-year overall survival in column 3. And so group 1 had a 5-year overall survival of 96%, group 2 was 84%, group 3 was 57%, and group 4 was 31%. So in summary, our study was a population-based study of more than 2,000 patients with differentiated thyroid cancer and distant metastases at the time of diagnosis. The most common site of distant metastasis in our cohort was lung and bone, and this is pretty consistent with prior studies. And then 2, unique from many other studies, our study used both Cox proportional hazard model to identify variables that have a global effect on prognosis, and we use survival tree analyses to identify patients that have a subgroup effect on disease-specific and overall survival. And so these findings provide much more granular data to risk stratify patients and to assist with treatment decision-making for this patient population. And then 3, our study highlights the relative importance of lung metastases in determining disease-specific and overall survival, especially for certain subgroups of patients. So when we looked in the literature, prior studies have reported variable prognostic effect of lung metastases among patients with thyroid cancer, with some studies similarly reporting an association with worse prognosis and others not finding that association. And we think that this heterogeneity is likely due to differences in the study methodology used. And so unique from the traditional methodologies, such as the Cox proportional hazard regression, which is we also use, the survival tree and these tree-based methods that we use allows for the identification of prognostic groups, assessment of relative importance of multiple factors in predicting survival, and the discovery of interactions between multiple factors without having to specify those interactions prior to the analyses. And then, as you may recall, our study identified patient age at the time of thyroid cancer diagnosis as one of the most important factors in determining both disease-specific and overall survival. And so in the survival trees for both disease-specific and overall survival, the first split was by age of less than or equal to 57 versus greater than or equal to 58 years. And so this to us suggests that for some patients with thyroid cancer with distant metastases, utilizing age as a continuous variable instead of just providing one age cutoff, it may provide greater level of granularity in prognosticating survival, as well as better inform clinicians when they're stratifying patients as part of that treatment decision-making process. So to kind of illustrate that point, so if we looked at a patient that was 72 with a primary tumor of less than or equal to 4 centimeters, and had non-lung metastases, for example, like liver metastases. And we looked at an 83-year-old with a primary tumor greater than 4 centimeters and distant metastases of any location. Based on the AJCC 8th edition, they would both be stage 4B, and that's associated with a 10-year disease-specific survival of less than 50%. In contrast, if we use our study findings on this study, the 72-year-old will have a 5-year disease-specific survival of 86%, and the 83-year-old will have a 5-year disease-specific survival of 27%. And then furthermore, for patients younger than 55 with distant metastasis, they would have an AJCC stage 2, which is associated with a 10-year disease-specific survival of 85 to 95%. Whereas in comparison, using our study findings, someone who is less than or equal to 39 years with lung metastases would have a 5-year disease-specific survival of 89%. And then a patient between the ages of 40 to 57 with lung metastasis would have a 5-year disease-specific survival of 62%. And so to wrap up on this, our study has pretty important clinical implications for both patients and clinicians. So specifically for patients with characteristics associated with poor survival, they may be candidates for more intensive treatment early on, or even earlier initiation of systemic treatment options. Whereas for patients with characteristics associated with improved or better survival, they may be candidates for less intensive treatment and may be able to transition their long-term surveillance from specialists to PCPs earlier, for example. So that's all I have, and thank you so much for your time and for listening.
Thank you very much, Debbie. That was a wonderful presentation. Very easy to understand, a little bit complex with the statistics and subgroups, but I think we got the message. Stephanie, you are on to discuss more about this particular paper and your own perception of management of distant metastasis. Go ahead, Stephanie.
Thank you. Can you just confirm, do you see my slides appropriately? Yes. Perfect. Thank you. All right. So I'm very happy to be invited and to speak today. And thank you to Debbie for that great presentation and for an excellent article and study, which I think is really important for us as clinicians who do manage patients with distant metastatic disease, and giving us a framework to think about this group of patients, which is rare and not ever going to be the majority of the patients you see. And so having more information in this group is really important. Okay, I have nothing to disclose. And so just to kind of start by summarizing some of the general terms that were presented, we know that distant metastatic disease is really rare, seen in only about 10% of patients who present with thyroid cancer. And it has this poor prognosis, and the percent that was presented by Dr. Chen, 53.5% 5-year survival. But overall, it's a group that is understudied. We don't have a great long-term studies of this population because it is so rare. And as a result, I think the approach to these patients has been sort of our traditional old thyroid cancer approach of one size fits all. And everyone's kind of put in one basket these patients with distant metastatic disease. In the staging system, in the treatment options, we sort of think of them all together. And I think one of the most important movements in our management and understanding of thyroid cancer today is that one size doesn't fit all. And we know that that's true in general with thyroid cancer. And I think that this study really accentuates the fact that that's true even in our patients with the most advanced thyroid cancer. It isn't one size fits all, and we need to understand a lot more of the details of these patients to really be able to appropriately manage them. I think as Dr. Chen spoke about sort of in her conclusions, one of the things that I thought was most interesting in her findings was this inclusion of lung metastases as as a important factor in determining prognosis. This is just, some older data, but studies that have really, in general, the thought process in distant metastases is actually that patients with pulmonary metastases have a better long-term survival than those with extrapulmonary metastases. So in this study, they found that the 10-year survival in patients with metastatic thyroid cancer with lung metastases, 10-year survival was 63%, whereas those with extrapulmonary metastases, bone, brain, liver, other sites, had 10-year survival of 25%. So again, I think Debbie started to discuss this, that perhaps the methodology, the population was a little bit different in their study, which really found that lung metastases were an important factor. But I thought that was one thing that was just, I think older age, bigger tumors, those are things we do always think about as associated with a poor prognosis. But the site of metastases and the lungs being worse was something that is a little bit different. So I do want to sort of point that out and bring that up just because it's a little different than previous data had shown. And then I do want to sort of, again, just go back to this study where I'm really going to focus on the the analysis where they were looking at disease-specific survival. And one of the limitations in using sort of the SEER database and these big database studies, we have really good demographic, age, size, those types of information. We don't have quite as good information about the details of the tumors or the treatments that the patients received. But I wanted to sort of first focus on the group 1. So we found this group that did really well. They had a disease-specific survival of 92%. That's very similar to what we may say for sort of our low-risk stage 1 or stage 2 patients. And I think in the body, they do talk a little bit about some of the treatments in this group. And so in that group 1, 93% had a total thyroidectomy and 69% received radioactive iodine. And I think, when we, in general, as clinicians, think about those patients that do the best in our treatments for thyroid cancer, one, obviously, the most complete surgery is the most important part. But then the second thing is that those that do continue to respond to radioactive iodine tend to do really well. And so here in this group 1, the ones that do well, we do have a majority of those patients having that more old traditional approach. And so again, this in just thinking about the radioactive iodine, when studies are done, those patients, even with distant metastatic disease who respond to radioactive iodine, they do have a normal lifespan and generally don't have a much lower rate of, dying from thyroid cancer. And it's really as we sort of shift over to those tumors and those patients who are not responding to radioactive iodine, where the overall, the long-term survival really changes. And so that studies have shown, radioactive iodine refractory tumors, 10-year survival can be as low as 10 to 30%. And so I just, while this study has kind of broken us down into 3 groups based on age, based on tumor size, I think some of the other underlying implications or things that are implied is some of the responses to some of the treatments that do exist. And I think really when we think about who would fall into that group 1, a lot of them are going to be these patients with radioactive iodine responsive tumors who can do really well after surgery and a dose of radioactive iodine. And then as we shift and look more at that group 3, the ones who have a much lower disease-specific survival, 41% at 5 years, And then we have to think about who are the people that are going to fall into that category, what are the people clinically that we see? And I think these, we know now they're going to be the older patients, maybe these larger tumors. I would say also, though, we look at this and only 59%, less than 60% had a total thyroidectomy. Well, that wasn't because everyone thought a hemithyroidectomy was a great way to treat this thyroid cancer. These are likely a lot more of a group of patients whose even primary tumor wasn't fully resectable. These are people who, when they went to have their total thyroidectomy, probably had tumors that were so large or invasive that they couldn't be removed completely. So from the start, we weren't even able to do a full treatment on their primary tumor. And then if we look at how many even received radioactive iodine, it was 36%, nearly only a third of these patients even got radioactive iodine. So again, what we have to think about is from the start, what was in this group of patients? Yes, they were older, they had larger tumors. These were tumors that likely were not a lot of them were not resectable initially. They were tumors that didn't appear to be ones that would respond to radioactive iodine. And so that also puts us into a separate group and pattern that we need to think about. And I think, again, in thinking these ways clinically and sort of what we think about today and how we manage thyroid cancer patients, the other things that the information that we have often today that isn't in the SEER database is things like the molecular basis of these tumors. And I think, again, if we think just in those two groups, the group 1 versus group 3, and think about the molecular basis of their tumors. And so much nowadays, especially in our advanced thyroid cancer patients, our treatments or our approaches depends on the molecular basis. And so again, those that are doing really well and have 5-year survivals over 90%, we would think molecularly, these are going to be patients more with RAS mutations, maybe RET-PTC mutations, but those mutations that are generally associated with well-differentiated tumors and RAI responsive tumors. And as we shift to think of those that are going to be in that group 3 with a much poorer long-term survival, these are the ones who are going to have not just necessarily a BRAF V600E mutation, but that combination of BRAF and TERT mutations. And that adding in that TERT mutation is really changes a tumor into a tumor that responds well to initial therapies to one that can be much more aggressive, less responsive. And sort of, again, this is just sort of data that looked at population of papillary thyroid cancer and sort of broke it down to those with wild type no BRAF and TERT versus those with BRAF alone. And these are the two top lines here where even no mutation or BRAF alone really didn't have a great effect on survival. But it was really when we added in a TERT mutation or the combination of BRAF and TERT where survival really dropped. And so I think, again, as we think about these groups of patients, what we have to think about is sort of what the molecular basis is, because that's going to be really important with how we think about our treatment approach. And so, again, I just wanted to kind of bring up what we have to guess a little bit because we don't have that information from the SEER database, but we can kind of start with this breakdown of prognostic groups and then think more about what else we need to figure out how we treat them. And that kind of jumps into, because we need that, not only do we need that, we need that information and figure out how we treat them, because today we do have options for treatments for these patients who have distant metastatic disease. We have these newer kinase inhibitors and systemic therapies focusing really on the molecular basis of the tumors. 3 are FDA approved. We have lots of others that we use in clinical trials or in, sort of more long-term, tumor mutation-specific types of treatments. But these different systemic therapies, while they haven't necessarily shown cured people of thyroid cancer, they have been associated with improved survival benefit, and I think are a real great tool in allowing us to have treatment options for those patients that are most at risk for advanced disease. And sort of by understanding this risk stratification, we can really help to determine which patients would most benefit from these systemic therapies. And beyond that, the other option is sort of the redifferentiation therapy. So sort of as I was talking about, that group of patients that do well are the ones that are going to be more responsive to radioactive iodine. But it's in that group 3, the ones that have a poor overall prognosis, where thinking about methodologies to make them respond to radioactive iodine can be much more helpful. And so building from this to finding out more about the molecular basis and some of these other tools that we have to address these advanced diseases is going to be really important moving forward. And as this study is sort of a good starting point for that. And so with that, I just wanted to kind of summarize that I think, this was a great study, and I think a really great help in us understanding this rare group of patients, this small group with distant metastatic disease. And I think, understanding that age and the size and the site of metastases are really important is where we need to start. And then from there, where we need to expand is sort of understanding from there which tumors are radioactive iodine avid, which tumors are PET positive versus PET negative, and the molecular basis of the tumor to really then further distinguish and further risk stratify the group of patients to those that have a poor prognosis and need these more advanced treatments. And I think the other key point here is that the treatments and the approach needs to be individualized. This isn't a one-size-fits-all, and we can't put all of our patients with distant metastases into one bag, but really individualize and understand that their behavior and the approach is going to be different. I think also sort of when we think about our treatments, what our goals are also need to shift, because while we're trying to prolong survival, we want to improve and relieve symptoms, improve quality of life, and improve survival, even though we may be in a situation where we can't necessarily cure them of their disease. And I would just stop to say that I think this is a great step in understanding this population better. And I think it's an area where we do need continued studies and a better understanding so that we can continue to build our therapeutic options. And with that, I will stop. And again, thank you so much for the invitation today.
Thank you very much, Stephanie. That was a wonderful discussion of a very complex subject. And I think everybody will completely agree with your final statement of individualizing the care. Before I go on to Dr. Chen, I have appealed to the audience. If you have any questions specifically regarding this subject, feel free to write on the chat box, and I'll be happy to discuss those further. While we are on our discussion, Debbie, you have anything to respond to Dr. Fish's comments? Especially, I know it is not part of your manuscript about the molecular markers and where we go from this, and then we'll go to some specific questions to you.
Yeah, I think Dr. Fish brings up very good points, and I completely agree with them. I think our study is meant to be a good starting point in terms of prognosticating for this very vulnerable patient population with thyroid cancer, distant metastases. The limitations in terms of the prognostications includes, the SEER, while it is very comprehensive, it does not currently have data on the molecular profile of these tumors. And I think, especially in this day and age, with the systemic therapies that are available, with the molecular testing availability, at least in the United States, it is an important next step to really understand, from a molecular feature standpoint, how are these tumors different, and how do we individualize treatments to the individual patient? So yeah, great points, Dr. Fish.
Thank you, Debbie. That was great. I have some specific questions while I'm waiting for other people to send their questions. Can you you did this great study with the SEER. Can you tell us from your experience, what are the pluses and minuses? There's a huge body of literature from SEER and NCDB. And every time you read, you kind of, step back and say, hey, is this all correct? Or is there some data analysis point or the entry issues? So you want to just expand on that, your own personal experience?
So in terms of our personal experience with SEER, we've had very good experience. We do consider it to be very comprehensive in terms of like the representation as well. So the coverage of SEER in terms of what they collect, it's meant to be representative of the US population as well. And so I think that's a positive. It's quite comprehensive in terms of like the data that we're able to get in terms of, like disease characteristics, patient characteristics, things like that. In terms of like the accuracy, they have a pretty robust mechanism by which to confirm the pathology from the sites that they're able to get the data from. So there's not really a question in our mind about, could it have been inaccurate entry just because of the robustness of that methodology. And it's pretty detailed on the website exactly about like how comprehensive their methodology is in terms of data entry and like confirmation of pathology and things like that. So we're never had a concern from that standpoint.
Great. That is quite helpful. I was just curious looking at your slides and publication. The age cutoff, 57.
Yeah.
So because we started with 45, we went up to 55 with the multi-institutional data. How did you come up with 57? This same question to both Demi and Stephanie.
So I would say that we, like as a group, we didn't come up with the number 57, but more it was from the analyses that we did. And so that's, so in terms of the tree-based methodology, which is the survival tree that we had used, the way that it works in terms of like, so I guess when I think about it, so the way that these survival tree analyses work is that you put in the variables into this model. And then based on the information, you have this large cohort of patients with thyroid cancer and differentiated metastases. And then they start to split the groups into, let's say, group 1 and group 2. And so what the goal is to have group 1 be very similar in terms of prognosis within group 1, but different from the prognosis in terms of group 2. And so based on that information, that's how the age cutoff of less than or equal to 57 and greater than or equal to 58 came in. So it was based on the data from SEER and based on the patient data. So we as a group didn't decide on that number. It was based on the information available, if that makes sense.
Yeah, no, that makes sense. But
I think that's why it's also it's quite important to note that it's not a predefined age cutoff, but it's based on the data itself. And so what that means is for the patients in our cohort that were aged less than or equal to 57, their prognosis in terms of like 5-year disease specific and 5-year overall survival is quite similar, but different from those with an age of greater than or equal to 58.
As we keep analyzing our data from different sources, NCDB, SEER, and other institutional analysis, I have a feeling that this age may change. There are some publications that 60 is a better cutoff. The Europeans use a different age cutoff. So I have a feeling that it's going to be a range rather than one particular number. Stephanie, you have any comments?
I mean, I think that, Ishak, I think that what you're saying is very important. I mean, because age is a continuous variable, I think that's the whole point of like, is there really a strong, is something happen on your birthday when you turn 58 versus 57? No, like it's just, and I think even with the AJCC, I think, while I think the recognition was that 45 was not the right age as to change in the staging. And I think the transition from 45 to 55 was sort of a decision of that's really going to be a more accurate number, but is it actually 55 or was it really 56 or was, or 57? I think probably, there was a feeling of let's make a cutoff that's more reasonable and appropriate, and yet also will identify those patients most at risk. And so I think, I think kind of this concept that older age is, as you get older, that the prognosis does change is really important. And I think when you're dealing with a continuous variable, each data set, the number may be just slightly different.
Great. Before we go on to a few more questions and the questions from the audience, I want to invite Mark Erkan, who is a TIRO guru and one of the leading thyroid surgeon in the country and the world. Mark, you have any comments about this particular subject?
Yeah, thank you, Ashok. So congratulations to Debbie on a really a wonderful presentation and study, and to Stephanie. I guess my question becomes, there's so many variables that you both have identified that impact on survival. What does the future of AJCC look like if we start to accumulate those variables? We will end up with tremendous substratification of our group of patients with metastatic disease. Internally, you're doing that. You're obviously identifying subgroups who are going to do better. And Stephanie, you identified additional variables not captured in SEER. What is a better, is this a worthwhile endeavor to further stratify the AJCC?
I think about it in terms of what is the goal. And as Dr. Fish had said, I think in this day and age, in terms of medicine, with the availability of the technology that we have, in terms of the testing, in terms of the available therapies, my take is that it's personalized medicine. And so for patients with thyroid cancer and distant metastases, the goal is to not say everybody in that category, which is quite broad, is very similar to you and the treatment is the same. I would say that for that patient specifically, like, how do we treat your cancer and how do we minimize symptoms, but also increase survival? And so, I think the next steps, and not necessarily in like the next year or so, but in the foreseeable future, hopefully, is really the molecular profile, because a lot of these systemic therapies, they do take into account what is the molecular profile of the tumor. And so, unfortunately, that data is not readily available in many of these kind of longstanding cancer registry databases, but within the United States, at least, that testing is available. And so hopefully the goal is to have it become more personalized and count for the molecular profile.
But I guess
Go ahead, Mark. Go ahead.
maybe for Stephanie, I mean, the goal of AJCC staging is really to be able to, obviously, to communicate about prognosis. And unless we do further stratify, it's not meeting its assigned goal here. And so I guess the question is this is really obviously at 10,000 feet, because what you're doing on an individual basis is not grouping them together. Stephanie, what's your thought about this? Is the future for us to really have accurate staging of these, or staging of these patients? Do we need to further stratify them according to what everything that's been discussed this morning?
Yeah, I mean, I think one of the things that you said, I think the whole, staging, there's a role for staging, and that's what the AJCC does, and gives us a stage, but then understanding how and that's going to be important for overall prognosis. But I think from a clinician standpoint, and from a clinician standpoint, understanding that there are different variables that come in sort of interpreting that staging is what becomes more important. I'm not sure that we'll ever have enough data or enough information to be able to have like an individual staging system that is so granular and discrete that every single person may have a slightly different staging. I just don't think that's practical. I think the AJCC gives us a framework, and I think it has important information and it gives us a framework. And then I think from there, studies like this study are really helpful to help us have a better understanding of within that framework where an individual patient falls. And so I'm not sure that it's something where the AJCC needs to change so dramatically. I think this is more information that then from a clinician standpoint and a study standpoint, that we have these information that can help us in developing guidelines and developing treatment plans for these patients. But the staging, I think, is a reasonable framework that we then have to build upon.
Very well said, Stephanie. I think you hit the nail very well. I think the whole philosophy of AJCC staging is we have to group the clinical features into 4 groups. And there are many other extenuating prognostic factors which we don't include, like, a stage 1 young person, why a particular person does not do well or why recurs, and whether that answer is in the staging system or the molecular testing, we don't know yet. But as we learn more, I have a feeling there are going to be many prognostic factors which will be included, but the staging may not change much. We have evolved quite a bit from stage 1, the edition 1 to edition 8. And the 8th edition is probably the crux of the current understanding of the biology of thyroid cancer. While we are on the subject, I have a question from the chat box. Maybe you may want to answer. Is there a difference between pulmonary metastasis and non-pulmonary metastasis as to the survival difference? Extrapulmonary versus pulmonary.
In terms of survival.
Correct.
So I would say this is where, if we look at the literature more broadly, this is where there's much more heterogeneity in terms of the data about whether a specific type of metastasis site is important in terms of prognostication. So in our study, specifically with the cohort that we have identified from SEER, the presence or absence of lung metastasis was very important in terms of determining that, whereas we included like brain, liver, one other.
Bone.
Brain, liver, lung,
Bone.
yes. Bone, yes.
Bone.
So brain, bone, lung, and liver. And so of all those metastatic sites, like in our analyses, the presence or absence of lung metastasis was very important. And so, I think the heterogeneity is likely related to differences in terms of the patient cohort that's used, as well as the methodology. So much more of the traditional methodologies, you have to identify like the variables prior to performing the analyses, whereas we did that as well as some of the traditional methodologies and what I described as tree-based analyses, where we don't have to identify the variables prior to performing them. And so that is one of the strengths of this. And so I do think that pulmonary metastasis is important in terms of prognostication, though in the literature it is quite variable based on the cohort and methodology.
What's the survival difference between pulmonary and extrapulmonary disease?
Sorry, can you repeat that?
Okay, what is the survival difference between somebody who has a pulmonary metastasis versus somebody who has extrapulmonary metastasis?
So there's not, so based on the survival trees, there's not it doesn't split necessarily into pulmonary metastasis and a non-pulmonary metastasis. It really depends on the subgroup. And so, for example, if someone is less than, let's say, less than or equal to the age of 57 with lung metastasis, it could be anywhere between like 62 to 89, whereas someone who's, less than 57 with another type of non-lung metastasis, it could be 88 to 97 in one specific example, but then the numbers could change. And so it's very much the subgroup of it. So there's not an easy answer to give. It really depends on like, what is the tumor size, what is the age, and things like that.
I have one practical question. When we see a young patient in our office, say 18-year-old or 25-year-old with pulmonary metastasis, we tell the patient and the family, don't worry, the kid is going to do very well. But if you look at your generic data, the survival is much poorer. So how do you explain this age difference between young and the generic numbers that you have presented? And Stephanie, this also goes to you later on. Is the question clear, Debbie?
In terms of the
Young
genetic,
people, the survival is excellent with pulmonary metastasis. There is a white, when you do the RAI, you see a huge uptake and you know this kid is going to do well.
I mean, I think I'm going to just help. I mean, I think that's your answer, Ashok, is that the thing about this data is that it doesn't break it down into, it has people less than 57. And so how many were 18 to 24 versus how many were 45 to 55? And while most of the majority received radioactive iodine, we don't really have data as far as the response or so I think that's where I think what you're saying and what I say and what we know clinically is, yes, a young person, even with lung metastases, typically they're very radioactive iodine responsive and they do great. And those people are in that group one, the ones that do really great, but we don't have this because it's more, I think, I mean, and Debbie can certainly, I think because it's more of this population based, we don't have as much of that discrete data to break it down in that way.
I was just curious from the data, Debbie. 69% of the patients received radioactive iodine. I think when we talk about distant metastasis, the first thing that goes through our mind is total thyroidectomy and RAI is the standard of care. So I was a little surprised that only 69% received radioactive iodine. I would have expected that to be 99 or 100%.
Yeah, and so I would say, we did as best as we could in terms of prognosticating these groups. But again, within the group, there is still some degree of heterogeneity. So like Dr. Fish has said, there's still a range of ages within each group. And then in terms of the treatment itself, in theory, what you're saying is true. I would agree with that in terms of the first steps, we would consider total thyroidectomy, radioactive iodine. But at the same time, if someone is not having it, is it really that they didn't get it? No one's really going to be, giving them a hemithyroidectomy in that context. Is it more that the tumor was unresectable or there was something else with it? And so I think it really comments on that if patients didn't have that there was some other circumstance that made it not feasible as opposed to someone just opting not to have that.
Okay, so we have got few minutes. Stephanie, I have a direct questions from your presentation. If I have a young patient now, 25-year-old medical student, 3 centimeter thyroid cancer, should I send the specimen for molecular testing to see if it's BRAF TERT positive? And if it is positive, what should I tell the patient and the family?
I mean, so I think what I would say, and sort of at least our approach at Memorial, is that we do not do molecular testing on everybody. And I think that many, especially a young person who responds well to the initial therapies, I'm not sure that the molecular testing at the initial diagnosis would change what we would do or how we would approach the patient. I think the times when the molecular testing becomes most helpful is in these patients with advanced disease, especially advanced disease that's progressing, where we need to be thinking about what are our options to manage this. And that's really where I think for right now, the information we have from molecular testing is most helpful, but we're getting more and more data. And I think, it may be that sometimes that, eventually we'll have data where the molecular testing is important of who we do give radioactive iodine to and who we don't give radioactive iodine to, because we know how they will respond. So I think that's still a work in progress. I don't think that everybody needs molecular testing based on what we have right now, but I think certainly a lot of the people in the group that this study was specifically focused on, the molecular testing is extremely helpful to help predict outcomes as well as determine treatments.
Thank
And
you.
I would say this.
Go ahead, Debbie.
I was going to say the same thing is what we do at Michigan as well. Not everyone gets molecular testing at the onset, but if there's concern or thought that you may require systemic therapy in the foreseeable future, we do then get genetic testing, molecular testing on the tumor itself.
Thank you very much. Mark, podium is yours for the last 1 minute.
Oh my goodness. I just want to thank you all for this wonderful discussion, always enlightening. Yeah, these are the patients that keep us awake at night. And so the more information we have and the better we can inform them and their families, the better. And so thank you for doing the research, and thank you for this wonderful discussion.
Thank you very much, Mark. And I would like to take this opportunity to thank both Debbie and Stephanie for their wonderful presentation and great discussion. I think we learned a lot from both of you today. And we also learned where we go in future in relation to locally advanced and distant metastases from thyroid cancer. Before we wrap up, I think close to 9 o'clock hard stop. I just want to invite all of you to be watching the thyroid podcast. I think this has been wonderful, and we will be looking forward to seeing you next week, Friday morning, with a presentation regarding molecular testing, a subject of lot of debate, lot of controversy, and lot of interest in the current fashion. So once again, have a wonderful day and the rest of the week. Thank you for being here.